Hi, everyone. Welcome to Rehabilitation and Movement Science Grand Rounds for March of 2023. Today we have Dr. Stephen Betz talking to us about cervical manipulation. And Dr. Betz earned his Doctor of Physical Therapy degree from the University of Pittsburgh, and he completed his residency training in orthopedics at St. Luke's University Health Network, where he served as chief resident. He's now enrolled as a fellow in training in the St. Luke's University Health Network Spine Fellowship. In addition to his clinical practice, Dr. Betz has served as an adjunct professor in the Doctor of Physical Therapy programs at both the University of Pittsburgh and St. Joseph's University, and is an assistant professor in the St. Luke's University Health Network Orthopedic Physical Therapy residency. Dr. Betz has been working in orthopedics his entire clinical career and has developed a specific clinical and academic expertise in mobilization and manipulation of the spine. Through his expertise, he's become a significant resource for colleagues and patients alike, and he currently practices at St. Luke's University Health Network's outpatient site at Nazareth. So make sure that you either scan the QR code or log in using the login information on the screen right now. If you missed that, it is in the chat as well. And if you still missed that, let me know and I'll be glad to get it to you. But understand that that information does expire at 12:30 tomorrow. If you're watching the recorded version, excellent. You're already in EADS, so there's nothing further that you need to do. Do make sure you take the quiz and the evaluation, otherwise you don't get CME credit for it. And if you have any questions, again, please reach out to me. So without further ado, I will turn this over to Dr. Betz.
Thank you, Steve. Hello, everyone. Appreciate you all attending today. Thank you, everyone, for coming. So I'm going to start with a little story here. About a year ago, 28-year-old college graduate student wakes up one morning experiencing a little bit of neck pain, some headaches, decides that she's going to go seek treatment for it. That's not an uncommon occurrence. If you're a college student, I'm sure many of us remember feeling exactly that way. So she decides to go find medical care in the form of a chiropractor and gets the treatment. And that same day winds up in the hospital, having experienced a stroke, and proceeds to spend the next month in the hospital, undergoing recovery, moved to acute rehab, still undergoing recovery, may never make a full one. And it leaves you wondering, cervical manipulation, is it all it's cracked up to be? Well, that's what we're going to talk about today. As Steve said, my name is also Steve, and I am currently the spine fellow with St. Luke's University Health Network, and I really want to share some of what I've come up with all of you as we go through this. Here's my designation and my disclosure information, right? And here are some of my learning objectives. This is kind of what we're hoping to review today: the current understanding of what the benefits are from manipulation and what the risks are, and then take that a step further and develop an understanding for the appropriate application of those techniques and how to minimize risk of adverse outcomes. So that's kind of what we're going to talk through today, right? And if that story sounded familiar to you, it's because it's true, right? This happened about a year ago. Like I said, her name was Caitlin Jensen, 28-year-old graduate student at a university that I can't remember in Georgia. And she woke up one morning with that headache and neck pain and went to a chiropractor and received a manipulation of her cervical spine, and 30 minutes later began to feel ill enough that her chiropractor called 911. And by the end of the day, she had gone into cardiac arrest, suffered a stroke, had a loss of pulse for a substantial amount of time, and received multiple surgical interventions. They discovered that there were 4 different arterial dissections in her cervical spine in the vasculature there. Or hospitalized for a month, acute rehab facility within 3 months. The last time I saw or heard anything about that story, she was still undergoing rehabilitation and was unable to walk on her own without significant assistance. And they're not really sure what her outcome is going to be, right? But they were very confident. All of those surgeons agreed that her injuries were a direct result of that cervical manipulation. And that story was covered substantially on lots of different news sources, some of them local, some of them global, some of them more or less reputable, depending on your outlook. But the story's out there, and it's easy to find if you want to find it, right? So that raises the $1 million question, or potentially in this case, more than $1 million, depending how things shake out. Should we be manipulating the neck if this kind of injury can happen as a result? But here's another disclosure. I have a personal bias here, right? I am what you might term a crack addict. And what I mean by that is I like providing this kind of care. I've had a lot of exposure to it. I have a lot of training in it, continuing to seek more training, continuing to get more input, and continuing to polish that expertise. But I like doing this, right? And so when I hear a story such as the one that I just shared with you, it makes me stop and wonder, what did we miss? What went wrong? What can we do differently? Interestingly, a colleague of mine is the one that shared this story with me. And when he told me this for the first time, his first words after finishing the story were, I guess I'm never touching a neck again. Two very different responses to the exact same situation, right? And that starts to make me wonder, can I, looking back through what we know, the science, what it shares with us, develop a well-reasoned defense for why cervical manipulation shouldn't be tossed out with the bathwater? Why should we keep that as a tool in our arsenal? What are the benefits there? And along with that, am I willing to change my own mind? As I research this, am I willing to let my own bias be challenged? And I'm going to share with you today what I came up with. Before we get into too deep into the weeds there, I quickly want to hit a couple of key factors here. What is spinal manipulation? Obviously, I'm a physical therapist and I'm speaking from that lens. But if you are not a physical therapist and you're attending today's lecture or you're listening to it later, I want to make sure we're all on the same page. So when I say manipulation, there are a couple different ways that we can define that. I've included a couple of them here. Some of them are PT focused, some of them are medical focused, but they all have a common thread running through them, which is demonstrated on this next slide. That flow sheet there, right? What we're calling a manipulation is it starts with a force applied to the recipient, which acts in a specific line of direction. That force creates motion at the joint, which includes separation or change in those articular surfaces, which then occurs with a cavitation, whether you hear it or not, and that leads to a manipulation. Okay, so for the purposes of what we're talking about today, we're going to assume that when I say that word manipulation, this is the flow that we're following. Okay. Now, why does it work? That's a great question, and people have been trying to answer that question for quite a long time. And I'm going to share with you just briefly some of what they've come up with, right? This team here studied a vast majority of the mechanisms that are proposed for manipulative therapy and tried to understand what's creating the response, what's happening, why does this do what we think it does. And they developed a comprehensive model which looks like that, which is straightforward. Take a quick glance at that and you understand without any questions, don't you? Right? Except not at all, because that's pretty complex, and that's kind of the point, right? Is the mechanism, the action by which physical therapy or chiropractic or osteopathic, any manipulation occurs, right? We don't really have a very clear picture of exactly what's happening, right? The proposed mechanism is that you get a large amount of afferent input that causes a neurophysiological cascade up to the brain and then resultant cascade again back down to the body, making changes, right? That's what we think is happening. And as far as we can tell, so to today's science, that's what we're going to work on, right? That's what we're working with. Despite that clear mechanism, the changes that happen through manipulation can be confirmed and studied by science. There's a bunch of them, including the two key ones here right now, right? The first is pain pressure threshold. If you're unfamiliar with that concept, it's effectively the amount of input your body, specifically your skin, can take before that stimulus is perceived by your brain as pain, right? So you've got on one side of the spectrum, hockey players being shoved into the boards, getting up and saying, yo, that was a good hit. And on the other side, you've got people whose clothes are driving them crazy just feeling it against their skin, right? And there's a wide spectrum there. And one of the things that they consistently find is that manipulative therapies can create a significant change or reduction in that threshold, right? So that you have a greater, I guess, an increase in that threshold. So you have a greater amount of tolerance for contact, for physical stimulus. Now, the key factor here is that that's found to only be true if you're starting from what we'd consider an abnormal point. So if you're a person who is not experiencing significant pain or symptom as a result of an injury, chronic condition, whatever, it's not as if you can go around checking into different chiropractors and developing a superhuman ability to be impervious to things, right? If you're experiencing issues, manipulative therapy is a proposed way to improve that tolerance. Again, same thing here with strength, right? There's a distinct augmentation in the percentage change of isometric strength, right, when compared to a sham treatment. But again, you're not going to turn yourself into Hercules by going around and getting manipulated if you don't have concerns. This is true for patients who are experiencing concerns and experiencing issues. Perhaps their pain is decreasing their volitional strength or some other mechanism like that. Manipulative therapy is shown to have a direct effect on that. If you're like me, sometimes neuroanatomy and neurophysiology can get a little challenging, so it's nice to have a visual representation of what that circuit is. This article is nice enough to provide one. I've shared it there for you as well. Okay, great. So we've kind of talked about what it is, why it works, what it does, but we're here to talk about the risks and the danger. So let's dig into that a little bit. Our story kind of focuses on cervical artery dissection, right? The story of this young girl, Caitlin, who had this horrible thing happen to her. The risk, as published in the literature, this article was updated this year, right? Is less than 1 in 100,000 individuals, right? Within that group, it is more common to injure the carotid artery, the internal carotid, than it is the vertebral artery. And interestingly, in both types of arteries, that injury most commonly leads to ischemic problems, even though it's a damaged tissue. They've found that in up to 90% of those cases, there is ischemic injury, the ischemic pathology that occurs. But obviously, adverse events are not limited to arterial problems. So here are a couple of others that we need to consider: injuries to nervous tissue, injuries to connective tissue, such as discs, bone, soft tissues, dislocation of the spine, etc. There are plenty of things that can go wrong, potentially, with manipulative treatment. But if you encompass all of those adverse events and develop a model that kind of compares how many people receive care to how many people have an injury or have a problem, that range of risk is quite broad, but can be 1 in every 2 million treatments, depending on what study, what resource you're looking at, right? So let's try to make some sense of that. The risk is documented, right? But what are some of the risks of other things that we're considering common, right? We're talking about this today because we all have a question in our head: should we be doing this? But there are other things we do without thinking about it that carry some risk as well. What are those, right? So again, depending on what resource you're looking at, NSAIDs carry a decent amount of risk, right? Just myocardial infarction, the risk can be as high as 8.7%, right? Relative risk of an adverse event to exercise, the thing that many of us are saying that we should probably stick to, right? You're a physical therapist. Why are you manipulating the spine? You know how to help people exercise. Stick to your exercise. Well, that carries a risk of an adverse event as well, 10.1%, depending on the population, right? It can be as high as that. The COVID vaccine, right? This scientific miracle that they were able to develop, right, in a fairly short amount of time. And then we were all very eager to try and participate in how do we get through and beyond this pandemic. That carries a risk. Again, just one symptom, AFib, can be as high as 3%. That's relative risk, right? So this is taking into account the number of times that treatment's provided to how many adverse events there are. So how realistic is that threat? There's a measurable association between cervical artery dissection and manual therapy. Yes, but there is an equal association between cervical artery dissection and visits to your primary care provider. We're going to dig into this in a second, but headache and neck pain are the most common symptoms associated with an arterial dissection. And if we factor in then another layer of science that's demonstrating that manual therapy is not shown to provide enough force to that connective tissue in those arteries to be the single mechanism of disruption, it starts to make you question, does this indicate that patients with arterial injury who are experiencing headache and neck pain just happen to be more likely to be going out to seek care like this, right? Is that there might be some of you who, when you have a headache or neck pain, especially if it's persistent, would go seek a chiropractor or go seek PT treatment. Some of you might go seek help from your primary care provider. And if that headache is being caused by that dissection, is that just what we're missing? And the end result is going to be the same regardless of the treatment that's being provided. Should the question we're asking instead not be whether or not we treat it, but how do we catch it? So another question you might be asking is, Steve, I get it. I hear what you're saying, but as physical therapists or other types of providers, there are other things we can provide that don't carry as much risk, right? We could do repeated movements, some sort of hands-off approach. We could do mobilization that doesn't go all the way up to a manipulative state. We can do manipulations at a different part of the spine. Why would I choose that risky technique when there are other alternatives at my disposal? And I'd say, yeah, that's a great question. And you're right, there is some risk, but I would ask you in return, does that risk outweigh the potential benefit, right? Because there is evidence that we're going to look at in a second for immediate and ongoing benefit of manipulative treatment for multiple categories of people. And I think this is where we're going to start rubber meeting the road, is that finding the person that belongs in these categories that will benefit from manipulative therapy versus the person who won't. That's the key. That's the clinical reasoning we're looking for. So let's start with, when should I manipulate, right? So there's clinical practice guidelines published in the physical therapy realm, but they apply to plenty of other disciplines as well. There's the clinical practice guideline for neck pain indicates two classifications that respond well to manipulation. There's neck pain where you have a distinct deficit in mobility of the cervical spine, and then there's neck pain with associated headaches. I included that extra line there, neck pain with radicular symptoms, right? That gray italicized piece, because other resources include that. And so I'm kind of adding it here because this is going to serve as a resource for you, hopefully. Let's dig into those a little bit more. Neck pain with mobility deficit, right? These symptoms, this is the person, this is what you're looking for. This is who you're recognizing coming into your clinic saying, this person falls into the green light column, right? Their symptoms, they may have unilateral symptoms, limited neck motion. They may or may not have pain referred to the upper extremity, right? And their pain is typically produced with changes to the neck, movement, palpation, spring testing, right? You can affect the neck and affect their symptoms, right? Similarly, neck pain with headaches, again, tends to be unilateral. They're non-continuous, right? And they come in that distribution or that progression right there, right? You start with pain, again, from the neck, often radiates up and around, or you may have it in two of those locations. And these headaches do not come with any sort of auditory or visual disturbance like a migraine would. These are a slightly different kind of headache. And again, their impairments would include difficulty with motion, symptoms being provoked by changing or affecting the neck, again, segmental mobility. And then there are a couple of clinical tests there as well, cervical flexion rotation test, testing the endurance of their musculature that you can use to build your clinical picture. Right. And so we've been trying to identify who fits these categories. Right. And they've created, they being the people who do all these kinds of research studies, they have created clinical prediction rules that kind of start to help match your treatments. So this is one for ruling in cervical manipulation. Right. There are four criteria there. It has to do with symptom duration, a change in range of motion, pain with spring testing, and, believe it or not, a patient belief that manipulation will help. And what they found is if you have all four of those variables as positive, then you have a perfect specificity that effectively rules itself in that that person will respond well to manipulation of their neck. 3 out of 4, it's a 0.94, their specificity, which is still quite high. Right? And I always include this when I talk about clinical prediction rules, that while that rule exists and is very helpful, the provider is still the one in the driver's seat, right? So that clinical reasoning is not replaced by this clinical prediction rule. It is aided by that clinical prediction rule. You may be able to use your experience and anecdotal evidence to supplement that and say when, you know, whether if someone meets 3 out of 4, but there's something that looks a little off. Right. This is the clinical reasoning aspect. So I just want to remind everyone that when we have rules like that that help inspire us to make better decisions, you're still the provider. You're still the one making that ultimate decision. So keep yourself in the driver's seat. Now, we talked about when people will respond well to manipulation. When should I not? Who am I looking to avoid? Right. There's a whole list of contraindications here. And if you were to go through them, many of them would stand out as, well, obviously, we're not manipulating that person. Active cancer, active fracture, etc. I have that one on the bottom of that list there highlighted, right? Headache and neck pain, unlike any other. So this is different from the headache we just reviewed previously. The location will be different. The intensity will most likely be significantly different, right? And usually they come in and say, this is a pain unlike any I've had before. If you hear that, your red flags should start to go up and you should start to ask more questions. Precautions, right? So these are not in and of themselves rule out criteria, right? But these are things you should consider as you're starting to learn who this person is. They may not have cancer now, but they had a history of it. They're pregnant, etc. There's some psychological elements that are on that list, right? And again, we're not going to go through them all. It's there as a resource for you. But there are some guidelines there to help you pick the person who is starting to look like someone that ought not to be manipulated. Right. And if you have anyone in your clinic that's demonstrating these signs and symptoms, right, whether they're acute onset or they've been going on for a little bit, these are the kinds of people that you would look at pretty closely and decide that you should probably be finding them a different provider other than, especially if you're not in emergency medicine, if you're in rehabilitative care like I am, they would be the kind of person you would look at and say, that person doesn't belong in my clinic today. Right. So how do I set myself up for success, Steve? Great question. First and foremost, pick your patients, right? You know the presentations you're looking for, know the presentations you're looking to avoid. We're not out here providing manipulative treatment to every neck that walks into the clinic. We're out here trying to identify necks that will respond well and necks that won't. We're out here trying to identify patients who are attached to those necks who will respond well and patients who won't. Right, so that's the key piece here. That's your first priority. Included here, I have some tables that I've pulled from a number of different resources, but one in particular from the International Federation of Orthopedic Manual Physical Therapists. They published a resource that is available on the internet and is cited in my references here, that dialogues specifically about arterial problems, right, with cervical injuries and how do we manipulate the cervical spine relevant to those arterial problems. I included these tables because I think they're a really useful and actually pretty cool decision-making tool. So effectively what they did is they went back retroactively through as many cases as they could find of patients who suffered both dissection and non-dissection events, vascular problems, vascular pathology, as it related to the cervical spine. And they were able to pick out symptoms, signs, etc., and categorize them in the frequency that they occurred, right? So remember I said earlier on that headache and neck pain are the two most common presentations or the two most common symptoms with cervical artery dissection. Well, you can see here, 81% of all dissection events that they were able to find included a reported symptom of headache. Somewhere between 57 and 80% included a reported symptom of neck pain, right? Go on to the non-dissection events, headache is still at the top of that list, right? Less significant, less frequent, but still at the top of that list, and then followed by things like paresthesia. Then they did the same thing with clinical signs, stuff that people picked up from their evaluation, trying to identify who was most likely to fall into this category. Who did we miss, right? And they did these specifically for dissection events. I didn't include the table here for non-dissection events. So vertebral artery versus internal carotid artery, right? And you can see there, so take for instance the vertebral artery dissection table, right? You have a 67% likelihood that that person who's experiencing a vertebral artery dissection has unsteadiness of gait and ataxia, right? Almost 70% of every case that experienced that was the end result demonstrated that sign, right? Like similar dysphagia, dysarthria, right? Almost half of every case that walked in that ended up having a vertebral artery dissection demonstrated that sign. And then they did the same thing. They looked at risk factors, right? So again, dissection versus non-dissection events, right? The number one risk factor for a vascular dissection event, recent trauma, right? From 40 to 64%. And then vascular anomaly, like a known aneurysm or something like that, 39%, right? So let's go back here and we start to use these tables to our advantage. I'm wondering whether or not this person is someone who should be manipulated. I'm thinking they might match the criteria, but I'm still not sure. Something feels a little fishy. If they report headache, all right, that might be the only symptom they're reporting. That's not enough to go on. But if they're reporting headache and neck pain, or let's say neck pain and headache and paresthesia, and I notice an unsteadiness of gait, or I notice upper limb weakness, right? Now I'm starting to piece these patterns together and pull from multiple of these different tables. If they're having a headache and they've got neck pain or they've got paresthesia in their upper arm, they're demonstrating unsteadiness of gait. And then I find out that they had a recent trauma, right? Or look on the other side, they have a current or a past history of smoking, right? I'm starting to piece these pieces together and realize this is the kind of person for whom an arterial injury is most likely to happen. Now my warning bells are going off because I've been able to produce a pattern, a clinical cluster of findings based on what the evidence shows us, right? Similar to the clinical cluster that indicated they may benefit from manipulation. Now I've got a clinical cluster that's indicating that they may not be a good candidate for manipulation. So these three tables, these 3 pages of tables are included for you here because I think these are what we refer back to and start to go, is that a symptom I should be worried about or not, right? And if I start seeing multiple of them show up from each of these different tables, now I'm really starting to realize that's the person I should be thinking to avoid, right? And then we build that into a flow here, right? So I won't read it thoroughly, but obviously we're starting from identifying whether or not some person has external, internal, environmental, whatever, and do they have risk factors for either of these dissections, right? And do they have symptoms that should warrant referral to emergency medicine? If they do, if they have a combination of risk factors and symptoms, then I'm going to refer them. If they don't have the symptoms, but then I do find through my physical testing that they have some signs, I should still refer them. And if I make it through all of those layers of security, then I can talk about initiating manual intervention, right? And that's effectively what we're all trained to do as providers, right? Is we sit down, we take a history, we obtain data from our patient, we use that data to plan how we're going to do our physical exam. Then we compare the data we obtain from the physical exam to the data we obtain from our patient's history and the interview we had with them, and we evaluate that critically and make the best decision regarding management. That's effectively what we do for any other case, and I'm campaigning what we do here, right? So once we've done that, our next step is to screen, right? We've made it through all of this. We've decided this patient belongs in my clinic today. This patient doesn't. This patient looks like they may be a candidate for manipulation. This patient does not. This patient looks like they may be at risk for one of these injuries occurring. This patient does not. And once I've gotten through all of that and decided, I think I'm ready to move towards manipulating this cervical spine, then we look at some of our other factors, right? Things like vital signs, testing their ligamentous stability, doing a neurological exam, observing their gait and coordination, because these things are all feeding back into those tables we were just talking about a second ago. Palpation or auscultation of a pulse, specifically the internal carotid artery. If you don't know how to do that, there are some great YouTube resources out there that can show you what you're supposed to do, what it's supposed to look like, or listen or sound like. I would encourage you to go out and seek those. But if you notice, especially if you're a physical therapist, we've been having this conversation for a while, notice what's missing from that screening list, right? We've had a conversation ongoing, at least in the physical therapy world, for a while, and it can then flow into other disciplines as well, about whether or not we should be testing for vertebrobasilar insufficiency with the VBI testing screens, pre-manipulative holds, looking for the 5Ds and the 3Ns, right? That the dysphagia, dysarthria, diplopia, the drop attacks, and the dizziness. Do they have ataxia, numbness, nystagmus, or nausea, right? And we're starting to realize that testing and that screen may actually be contraindicated, right? The most recent data, the most recent literature that's coming out is suggesting we should not be doing that, because a negative VBI test is effectively inconclusive, but it provides a false sense of security to a provider who should have done a much more thorough screen and would have gotten more benefit from it. And I remember when I first started to learn how to do cervical evaluation or cervical manipulation, I pretty much used my VBI test as, I know it's not very good, but it's the best I've got. So if they pass that, I think I'm okay. And I'm realizing that gave me a false sense of security as a young provider. And I'm regretting that eagerness to just jump in and go full throttle, but also recognizing that that's something we should be sharing moving forward, right? Use your clinical reasoning, use your intelligence and your training to be able to identify who is most likely a candidate and who's not. Don't rely on a single test to do that work for you. And then the last piece in setting yourself up for success is understanding your technique, right? You should know how to perform the skill well, and you should know what elements to avoid, right? They talk about how end range rotation is the position that puts the absolute most stress on those arterial tissues. So that would be a position that you'd want to try and avoid and learn manipulation in a much more mid-range position, right? Prolonged holds would be another one. If you do not know how to do these techniques, I would encourage you to seek out training people, whether they're colleagues or classes, that can show you how to start doing these things and get the practice and become familiar with them. Unfortunately, this is not the venue, the lecture, to be able to dig into how to do that, but I am more than happy to share it with you if anyone wants to seek me out and ask me questions about that. I enjoy engaging with this, and I enjoy showing other people how to do it and how to do it successfully. But that would be the last critical component, right? When we think about providing treatment, we often think about the treatment itself being the first thing you learn. And I would argue in this case, the treatment itself should be the last thing you accomplish, right? Identifying who needs the treatment is the first thing you should learn, so that you do minimize your risk, right? So to conclude all of those thoughts, I would argue at the end of all of my research and all of my study into this topic, that cervical manipulation is indeed a useful tool. In my case, a physical therapist arsenal, but if you're a chiropractor, if you're an osteopathic physician, whoever, right, you want to continue to apply cervical manipulation as a tool for your arsenal, I think that's totally reasonable. I think it's indicated, and when it's indicated, it's highly effective. I think when it's not indicated, that's when it carries some inherent risk. The key to success is being able to know, indeed, when it is indicated and when it's not. So if we go back, cycle all the way back to our story with that young woman, the college student who experienced the horrible reality that she's now living, I would love to know more about that story and about that case. And unfortunately, we never will. But hopefully, now that we've had this conversation, you can start to think through whether or not just the way that story was presented in the local news is an effective enough means of you choosing how you provide care for the future. I would hope that it's not. I would hope you'd think a little bit more critically about cases like that, asking questions about what other symptoms did she demonstrate that we don't know about? What was her history? What was her exposure previously? What kind of manipulation was done, etc. There's a lot more meat left on that bone, and I wish we could go back and learn a little bit more about it so that we can all become better providers from it. But bottom line is, a useful skill should not be, and this is my personal stance on this, but I hope that I've demonstrated appropriately today why this is true. A useful skill should not be completely disregarded out of fear, right? Yeah, there is a risk to cervical manipulation, but there's an equal or greater risk to plenty of other things we do every day, right? And I would stand that an aversion to risk is not in and of itself a good enough reason to choose to opt out of an entire category of treatment techniques, right? Looking at one scary story that happens in the news and saying, if that can happen, why would I ever want to do that? I would encourage you instead to look at a story like that and go, how do we move beyond it? How do we get better? How do we learn from it? And how do we grow? And I think there's plenty of room for all of us to grow in this context. But our skills as highly educated providers should not be overlooked, right? Our job is to advocate and support our patients. Our job is to provide our patients the best care we can to solve the problems that they are bringing to us, right? And if we can't solve them, how do we help manage them? How do we encourage and come alongside that person? That's what we all agreed to do when we became clinicians. And our skills, as we learned how to do that, should not be overlooked. So we need to make a smart call. Yes, we prioritize patient safety, but we do that by being thorough and by examining people in a way that moves us towards the best possible outcome for both of them, right? And also indicates what our treatment should be for us. Kind of meet there as those two things come together, and then be confident as those treatments are matched, right? The research demonstrates the treatments that work, and the research demonstrates the people for whom that treatment does not work. And we can be confident in what that science has demonstrated to us. So hopefully, throughout the course of what we've talked about today, you are able to learn effectively, right? Obviously, again, my bias, like I started out saying, but also a broad spectrum of what people have been trying to understand about these concerns over the course of years and years. And I want us all to choose to think more critically about who we're providing treatment to, but also how we're choosing which treatment we provide and whether or not we're letting our own biases affect whether or not we're moving towards or away from certain things. I want to encourage you not to let fear be the bias that moves you away from something, but be critical thinkers because you've been taught how to do that. And I am confident that we can work on that and move our profession forward together. So thank you all for hearing what I had to say. I had a bunch of resources there for you, and I'd be happy at this point, Steve, I can't see the video or anything. You're good? Oh, okay. So I'd be happy to take any questions at this point in time.
Please feel free to unmute yourself if you have a question or type it into the chat. All right, just to kick things off, I do have a question. So
Yep.
in all of your research, I noticed that you didn't comment on diagnostic imaging at all. Should people be getting X-rays, MRIs in order to rule out risk for dissection, or would that be helpful?
Yeah, so I didn't include it at all, partly because, at least in the literature that pertains to the type of care that I do, right, the access to that isn't very high, and so they did a lot of research on how we can do this screening beyond that. But what there is out there is effectively saying that it doesn't really lend us anything we can't already learn from our clinical reasoning, right? From our abilities as as assessors, as testers, as evaluators, and the skills that we have to do that, right? We are able to identify at an equal rate, or effectively an equal rate to what imaging would identify. And sometimes imaging like that VBI screen can be a false sense of security because it's a still picture and we know that this is a dynamic structure. So there's not really a whole lot out there because they don't see it as a contributing factor that could potentially benefit, right? It's also incredibly expensive.
So if I'm understanding your answer correctly, getting it doesn't help at all. It doesn't help reduce the risk of injury because as long as somebody has done a thorough physical examination.
Right. Or at the very least, it doesn't help to any reasonable level, right? This physical examination you are able to do as a physical therapist or as an osteopathic physician or whatever is as effective as that image.
Thank you. The next question we have is there a difference in risk regarding cervical manipulations targeting more mid-cervical versus upper cervical lobes?
That is an excellent question, right? And the answer, as best as I can understand it, is no, because the type of manipulation you're doing should not be, it is not putting strain on those structures, regardless of where you're doing that manipulation. Does that answer that question? I mean, effectively, we're showing that the amount of force we're providing when we do a manipulation, especially if it's not at an end range, is not enough to disrupt those tissues. And it doesn't matter if it's at C1-2 or if it's at C5-6. We're still not providing enough force to really make a problem there.
Thank you.
You're welcome.
What other questions do you guys have? Something you didn't mention up there is, and perhaps you don't know these off the top of your head, but is there a risk to taking, when I have a headache, frequently I will take ibuprofen or some other type of NSAID or acetaminophen or some other type of analgesic. Is there any risk to taking those versus cervical manipulation or anything else?
As in, does that increase your risk of cervical manipulation being problematic?
No, just is there any inherent risk in taking those over-the-counter medications with regard to having serious side effects?
Well, yeah, so there is some risk, right? We did include that a little bit in that slide where we went back, and I picked out one specific outcome, which was myocardial infarction, but the list that I pulled that from had like 25 or 30 potential adverse outcomes with varying degrees of risk. I picked one that would stand out as, oh my goodness, I didn't realize this could lead to that, right? But yeah, yes, there is some inherent risk. I would argue, based on the math, more inherent risk than getting your neck manipulated. And again, not that I'm not a pharmacist, right? So I'm not discouraging what you choose not to use, but when we compare the two, that's what we're kind of talking about. One is not necessarily better than the other. At least that's not what the science shows.
Thank you very much. If you do have any other questions, please feel free to reach out. But we will conclude today's presentation. And thank you very much for this wonderful presentation. Very well put together. And I think it was very enlightening on the risks and the benefits of cervical manipulation. Make sure you do complete your quiz and take the course evaluation so you get credit for this.
Thank you, everybody.